Now let's move on to the alpha-2 receptor. Unlike alpha-1 receptors, which are mainly located on effector organs, alpha-2 receptors are found primarily on the presynaptic nerve terminal. Their main function is to provide negative feedback and regulate the release of norepinephrine. Mechanistically, alpha-2 receptors are coupled to the GI protein. Therefore, when these receptors are stimulated, they decrease intracellular cyclic AMP levels, which in turn inhibits both the synthesis and release of norepinephrine from the nerve terminal. As a result, less norepinephrine is available to stimulate alpha-1 receptors and other adrenergic receptors. If less norepinephrine is released, there will be less alpha-1 mediated vasoconstriction. Consequently, blood vessels tend to relax, leading to a decrease in blood pressure. This is why alpha-2 agonists such as Clonidine are used as antihypertensive drugs. However, alpha-2 receptors are not found only on presynaptic nerve terminals. They are also present on platelets, where they promote platelet aggregation. Now, as we all know, platelets are non-innervated structures. They are not attached to sympathetic nerve terminals. Therefore, the question arises, which catecholamine acts on these platelet alpha-2 receptors? The answer is epinephrine. During a fight or flight response, the sympathetic nervous system not only releases norepinephrine from nerve endings, but also stimulates the adrenal medulla to release epinephrine into the bloodstream. This circulating epinephrine can then reach platelets and activate their alpha-2 receptors, leading to platelet aggregation. Now, why is this clinically important? Now, suppose a patient has hypertension. As we know, patients with long-standing hypertension are more prone to developing atherosclerotic plaques in their blood vessels, including the coronary arteries. In such a patient, increased platelet aggregation could potentially promote thrombus formation over an existing plaque. Therefore, although alpha-2 agonists are useful antihypertensive drugs, their ability to promote platelet aggregation should also be kept in mind as a potential adverse effect. Another important location of alpha-2 receptors is the beta cells of the pancreas. Remember that alpha-2 receptors are coupled to the GI protein, so their activation decreases cyclic AMP levels and inhibits insulin secretion. As a result, stimulation of alpha-2 receptors leads to reduced insulin release from the pancreas. Now let's think about the clinical significance of this effect. Suppose we use an alpha-2 agonist to treat a patient with hypertension. As we know, hypertension and diabetes frequently coexist, and many hypertensive patients either already have diabetes or are at high risk of developing it. In such a patient, activation of alpha-2 receptors on pancreatic beta cells will further suppress insulin secretion. As a result, blood glucose control may worsen.